Hello everyone, I am Dr. Afzal Malik, Senior Physiotherapist from the UN Mehta Institute of Cardiology and Research Center. As we all know that in the series of continuous physiotherapy education, till now various topics has been discussed. So in continuation to that, today we are going to see about early mobilization after the cardiac surgeries and its profound impact on patient recovery. Along with this, we will also see that why early mobilization isn't just beneficial but essential in improving the patient outcomes. Before starting the presentation, let us have an overview of the key points that this presentation will cover. First of all, in introduction, we will see that what early mobilization is all about. Second, we will see why early mobilization is necessary. Third comes the complication of prolonged immobility. After that, we will see what will be the type of mobilization and what are the exercises that we can prescribe to the patients. Later comes the physiological effects and benefits of early movement, that is to the patient, and at last we will see what should be the precautions that are taken care of. Introduction. So for the decades, the conventional wisdom was to keep patients still to the rest. We believe that rest was the paramount of healing. However, this traditional approach, while well-intentioned, often prolonged the hospital stay and delayed the patient return to independence. Today, there is a paradigm shift in the patient care. Early mobilization is a cornerstone of modern rehabilitation and critical care. It's about getting patient moving safely and purposefully as soon as medically stable. Globally, people recover from critical illness and get discharged from ICU setup. However, it has been noticed that the patient develop weakness, probably due to their prolonged period of immobilization. The post-intensive care syndrome was the term used that described the worsening of physical, mental, and cognitive problems. Early mobilization of critically ill patient is a safe option with additional benefit of improving the functional outcomes. The term mobilization in intensive care unit is referred as the physical activity performed to the intensity that can bring about the physiological changes. Early mobilization after cardiac surgery is a crucial part of recovery and has numerous benefits. It is generally recommended to start as soon as safely possible, often within the first 24 hours, or even the day of surgery, once patient is hemodynamically stable. Early mobilization after cardiac surgery is a crucial component of post-operative care, aiming to prevent the complications, reduce hospital stay, and improving the functional recovery. It involves the initiation of physical activities like changing in position in bed, sitting up, standing, and walking, with the goal of gradually increasing the activity levels. Now we will see why early mobilization is necessary. So it improves the respiratory function, helps to clear the lung secretion, improve lung expansion, and prevent complications like pneumonia and atelectasis. In cardiovascular health, it promotes better circulation, reduces the risk of blood clots, that is DVT and pulmonary embolism, and helps the heart and cardiovascular system to adapt to increase in activity. In musculoskeletal system, it reduces the muscle weakness and loss, prevent muscle deconditioning that can occur due to prolonged bed rest. Pain management. Surprisingly, the gentle movement can actually help to manage the pain and discomfort by improving the blood flow and reducing the stiffness. Now, psychological well-being. Patients often feel more controlled, less anxious when they are able to move and participate in their recovery. Shorter hospital stay. Early mobilization is a key component of fast-track recovery protocol, leading to quicker discharge from the ICU and hospital. Now it improves the overall functional capacity, helps the patient to regain their strength and ability to perform daily activity faster. Now what will be the complication of prolonged immobility? If patient is immobile for prolonged time, then what will be the complications? So in respiratory system, it causes the retention of secretion, reduces the respiratory excursion, pneumonia, and ultimately atelectasis. In cardiovascular complication, it includes orthostatic hypotension, deep vein thrombosis, hypovolemia, and embolism. In gastrointestinal complication, it includes the decrease in motility and ultimately lead to constipation. Musculoskeletal complication include muscle shortening, weakness, and wasting, which in turn causes the functional denervation, joint contracture, bone demineralization, and heterotopic ossification. Neurological system is also get affected. It is get affected by polyneuropathy due to reduced microcirculation at nerve. In endocrine system related complications include hyperglycemia with insulin resistance and catabolism. In integumentary system, it causes the pressure ulcers. Ultimately, the psychology of person is get affected, causing depression and delirium. Now the prescription of early mobilization. What type of mobilization we can prescribe to the patients? So there are various steps in the prescription of early mobilization. Step 1 include identifying the contributing factor towards the oxygen transport deficit, understanding the pathophysiology of a condition or the disease, extrinsic factor that affect the patient care, intrinsic factor related to the patient, and relative immobility, that is the state of limited movement, often comparison with the previous state. Step 2 comes the determining the specific need for mobilization and subsequently the form of mobilization or exercise that will address the oxygen transport deficiency. Step 3 would be the matching the selected mobilization technique or exercise type to the patient's oxygen carrying capacity. Step 4, setting the dosage, that is the intensity to match the safe limits of oxygen transport to the patient. Step 5 would be combining the body position with the following maneuvers such as thoracic mobility exercises and range of motion exercises, that are the active, passive and active assisted exercises, and coordinating breathing control with the body movements, coughing supported by self or others. Step 6, use of oxygen transport and its indices to monitor the dosage of mobilization, not a fixed duration of time. Step 7 would be repeating the mobilization as frequently and safely as the beneficial effects are tolerated by the patient. Step 8, the intensity of mobilization stimulus can be increased as long as the patient capacity permits. The effect of mobilization stressor, keeping the oxygen transport as the benchmark, constantly monitoring the vitals. Now comes the types of mobilization. First, bed exercises. In bed, turning. Regular turning in the bed to prevent pressure source and improving the lung expansion. Deep breathing exercises and coughing exercises are the crucial for lung health. Ankle pump and leg exercise to promote circulation and prevent blood clots. Later comes arm and shoulder exercises. Gentle movement to prevent stiffness, but we should be mindful for the sternal incision, often with the sternal precautions. Second comes sitting up in the bed on the edge of the bed. This helps to improve the lung function and prepare the patient for more active movements. Once stable, the patient will assist to sit on the edge of bed and their feet dangling. This helps the blood pressure regulation and preparing for standing. Later comes standing and walking. As tolerated, patient can gradually progress to standing at bedside and then walking short distance in the room or the hallway. Starting with very short walks around the room, gradually increasing the distance and duration as tolerated by the patient. This might be assisted by a physical therapist or nurse. Another form of mobilization is chair sitting. A sitting in chair can provide change of scenery and allow for the rest periods. Stair climbing. In later stages of recovery, patient may be able to climb the stair under the supervision. Now, what is the typical early mobilization protocol? So from day 0 to day 1, when patient is in ICU, what we can implement is the passive range of motion exercises if patient is sedated or intubated. Second, sitting up in bed or on the edge of bed, dangling legs once patient is stable. Along with this, the breathing exercises such as deep breathing and incentive spirometry to enhance the lung function. Next comes from day 2 to day 3, when patient is shifted to the step-down unit. Now, transferring patient to the chair for the meals, that is 1 to 2 times daily. Short walks, that is about 50 to 100 feet with the assistance from a physical therapist or nurse, and we can use walker if needed. Along with this, upper body exercises such as arm raise, elbow movements, wrist movements to prevent the stiffness, avoiding strain on the sternum. From day 4 to day 7, that is up to the discharge when patient is in ward, we can increase the walking distance, that is around 200 to 400 feet, 2 to 3 times daily, climbing few stairs under the supervision to prepare for home activities, and educating the patient about the activity limits, such as avoiding lifting heavy weights for 6 to 8 weeks to protect their sternum. So in this image, we can see that patient had undergone the surgery and his patient is shifted to the ICU. Now the team of the doctor decided to implement the early mobilization. After that, with the help of physical therapist and nursing staff, patient is made to sit. After gaining the confidence and with the stable vital signs, patient is made to stand with support. Ultimately, after gaining the confidence, patient will start walking under the supervision of nursing staff and medical professionals team. This image shows the various exercises that we have already discussed. First of all, in bed exercises, foot pumps, leg lifts and turning, that is the ankle toe movements. When patient is sitting on the edge of bed, that helping the patient to get to the edge of the bed, guiding their feet over the side of bed and supporting their balance. When patient is standing, ask the patient to rise on the count of 3 and assisting the patient to stand. Assessing their balance and sign of distress or weakness, and asking a client to walk in a place. Now when patient is walking, ambulate a short distance and maintain a grip on a gate belt, having a wheelchair or a seat behind the patient if needed. In ICU setting, early mobility is crucial for improving the patient outcome, reducing the ICU length of stay and preventing complications such as muscle weakness and delirium. Several tools and systems helps to guide the physiotherapist in safely implementing the early mobility. The traffic light system is one such tool that is widely used to help and guide the clinical decision based on the patient's stability and its response to mobilization. The traffic light system classifies patients into 3 categories: green, yellow and red, based on the safety indicator which helps the physiotherapist to make real-time decision. Green, the patient are cleared for mobilization, indicating stable vital sign, cooperative state and minimal sedation. Yellow, the mobilization may be performed but with the caution. This patient may have fluctuating vitals or moderate sedation and require close monitoring and potential assistance. Red, in this mobilization is contraindicated. This may be due to the severe instability, high ventilatory support requirement or other critical concerns. In this image, we can see that patient is made to sit from lying by the help of physiotherapist, and ultimately patient is transferred to the wheelchair from the bed. Now, what will be the barriers to the mobilization? So, despite of the numerous evidence-based benefits of early mobilization, implementing this program within the critical care setting remains a challenge. These barriers range from lack of time, equipment, poor staffing, as well as the poor communication across the team and unpredictable nature of ICU. If we look at the patient level, then what will be the barriers to the mobilization? So first of all, physical barrier include the lack of devices and equipment. Second comes the respiratory instability, distress and ventilator asynchrony. Third comes the excessive pain. Fourth, the poor nutritional status, excessive weakness, deep sedation, delirium or agitation, lack of motivation, lack of consent. Patient is very anxious, fatigue and sleepiness. Now, if we look about provider level, then comes the lack of knowledge of the benefit and expertise to effectively implement the early mobilization. Nervous or skeptical clinician, concern about unpredictable nature of ICU, limited or lack of staff support, lack of planning and coordination amongst the team member, and lack of communication. Other barriers includes IBP, pacemaker, ECMO, excessive drain, abnormal ECG rhythms, hypertension or hypotension, multiple inotropic support, low ejection fraction or open chest. The first image shows the ECMO machine attached to the patient. Second shows the IBP machine, that is intra-aortic balloon pump. Third image shows the abnormal ECG. And fourth image shows the patient is having open chest. Now, what will be the physiological effects of mobilization? So in pulmonary system, it increases the regional ventilation, regional diffusion and regional perfusion. It increases the tidal volume, increases the efficiency of respiratory mechanics. It reduces the airflow resistance and increases the flow rates. It increases the zone 2, the area of ventilation and perfusion matching. It increases or decreases the breathing frequency, increases the strength and quality of cough, increases the mucociliary transport and airway clearance, increases the distribution and function of pulmonary immune factors. Second, in cardiovascular system, it increases the venous return, increases the stroke volume and heart rate, increases the myocardial contractibility, increases the cardiac output, increases the coronary perfusion and increases the blood volume. Third comes the peripheral circulatory effect. In this, it reduces the peripheral vascular resistance, causing increase in blood flow and increase in the peripheral tissue oxygenation extraction. Fourth comes the lymphatic system. In lymphatic system, it increases the pulmonary lymphatic flow and pulmonary lymphatic drainage. Hematological system, it increases the circulatory transient time and reduces the circulatory stresses. If we look about neurological system, it increases the arousal and increases the cerebral electrical activity, increases the stimulus to breathe, increases the sympathetic stimulation and increases the postural reflex. In endocrine system, it increases release and distribution and degradation of catecholamines. Integumentary system, it causes cutaneous circulation for thermoregulation. Multisystemic effect include reduction in the effect of anesthesia and sedation, reduces the deleterious cardiopulmonary effect of surgery, reduces the risk of loss of gravitational stimulus and exercise stimulus. Now we will see the benefit of early mobilization. So first, reduce postoperative complication. Early mobilization helps to prevent the complication associated with prolonged bed rest, such as deep vein thrombosis, pulmonary embolism, pneumonia, and muscle weakness. It improves the functional capacity. It enhances the muscle strength, lung function, and overall physical capacity, allowing patient to return to daily activity more quickly. It reduces the hospital stay. By promoting faster recovery and reducing the complications of early mobilization can lead to the shorter hospital stay, potentially reducing their healthcare cost. Fourth come enhancing the psychological well-being. Physical activity can improve mood, reduce anxiety, and promote a sense of well-being. Last, it improves the blood flow and wound healing. Walking improves circulation, which aid in faster wound healing and reduces the risk of infection. Now, important consideration and precautions. Now, what should be the precautions that are taken care of? First, sternum precaution. Patient will have specific instruction to protect their sternum while it heals. This typically involves avoiding pushing, pulling, or lifting heavy objects, using a hug pillow or splinting in their chest when they cough or they get up. Pain management. Adequate pain control is essential to allow the comfortable movement. Monitoring vital signs. Healthcare professional will closely monitor the blood pressure, heart rate, oxygen level, and any sign of discomfort or complication during the mobilization. Individualized approach. The pace of mobilization is always individualized based on the patient's tolerance, progress, and any underlying condition. Physical therapy. A physical therapist plays an important role in guiding and assisting the patient through their mobilization program and providing exercises and education. Now, if we look about the recovery improvement metrics, the early mobilization significantly enhances the patient outcome and speed up the recovery, leading to shorter hospital stay and better overall health. It has been observed that 30% of reduction in the hospital stay duration is noticed when patient is mobilized early. So, early mobilization enhances the healing after the cardiac surgery. I hope this presentation will help you and enhance your approach towards the patient. In the end, I would like to thank head of the physiotherapy department, my fellow colleagues, and photography department of UN Mehta Hospital. Thank you.